We will just wait one more minute, and then we'll get started. Okay, it's 2 minutes after 12, so we'll get started. And sure, we'll have some students join us. But thank you all for joining us again today for our June edition of What's New in Addiction Medicine. This is the last presentation for this particular cohort of fellows. So we have Dr. Tyler Wilson joining us today. To bring things home. My name is Paxton Bach. I'm the Fellowship Director for the Addiction Medicine Fellowship, and I will introduce Dr. Wilson and then turn it over to him, and then be here to field questions at the end of the session. So with that, I'll provide a brief introduction. So today we have with us Dr. Tyler Wilson. Dr. Wilson's one of our addiction medicine fellows here at the BC Centre on Substance Use and a graduate of the UBC Internal Medicine Residency Program in Vancouver. He's completing concurrent fellowships both in general internal medicine at UBC as well as our addiction medicine fellowship here at the BCCSU. Dr. Wilson's passionate about improving access to care for patients with addictions, and he's especially interested in the overlap between addictions and complex chronic diseases. He hopes to use his career as an internist to improve internal medicine physicians' approach to addressing the complex health issues of patients with substance use disorders. He is here today to give us a presentation called Time to Let the Dogma Out: Cardiac Disease and the Safety of Beta Blockers and Stimulant Use Disorder. So with that, I will turn it over to Dr. Wilson.
Thanks very much for the introduction, Paxton. I appreciate it. Yeah, and my first acknowledgement, I should thank the other addiction medicine co-fellows for their assistance with coming up for this title. Coming up with an adequately witty title for the What's New in Addiction Medicine talk has become a source of great consternation for the addiction medicine fellows. So anyone who got a snicker, you get full credit, and anyone who's rolling your eyes, I'll take full responsibility. I'll just start this presentation off with a land acknowledgement, which I think carries extra weight in the context of the recent findings at the residential school in Kamloops, and of course also the recognition that First Nations people suffer from a sort of disproportionate burden from the harms of substance use disorders due to sort of the effects of colonialism and structural inequalities. And so with that in mind, I just like to respectfully acknowledge that I'm a humble guest on the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh Nations. I do not have any conflicts of interest to report. And then regarding what we're going to be talking about today, so I'll start off with an introduction to stimulant use disorder. And then the sort of meat and potatoes of this presentation is just to go into, speaking to that overlap between chronic diseases and addiction medicine, to go into learning a little bit more about some of the cardiac diseases that are associated with chronic stimulant use. And in particular, we're going to focus on a class of medications called beta blockers. I'll explain a little bit more for folks that maybe aren't as familiar with this area of medicine, what beta blockers are. But we're going to go into a sort of a deep dive into the safety of beta blockers in the setting of stimulant use, review the role of cardiology, and then prescribe an approach to, or propose an approach to prescribing. The reason that this is such an important topic is although beta blockers are a life-saving, very important therapy in cardiology and internal medicine, there has been a great deal of controversy about their safety in the setting of people who use stimulants. This is a consensus statement from the American Heart Association published in 2008 that sort of is, I think, some of the initial concern around beta blockers in the setting came from, and they make a statement: the use of beta adrenergic antagonists, which means beta blockers for the treatment of cocaine toxicity, should be avoided in the acute setting. And they're specifically talking about acute MI. Now, this is a really specific kind of statement where they're talking about beta blockers in a very kind of narrow area. But because of this concern, there's been an enormous kind of expansion of that concern to the point that cardiologists and internists have become very, very hesitant to prescribe beta blockers for anyone who uses stimulants at all, ever. And this is problematic because beta blockers are life-saving medications for a number of cardiac conditions, including congestive heart failure. And for most patients, we would advocate very, very strongly for them to get on beta blockers. If there was, say, a side effect that was causing problems for a patient to be on beta blockers, or an issue with cost, like most internists and cardiologists work very, very hard to troubleshoot that, because we believe so strongly that these medications save lives and improve quality of life. And on the other hand, for patients with stimulant use disorder, most internists and cardiologists would very confidently withhold these medications, not even have a discussion with the patient about the risks and benefits, just say, oh no, for sure, this is not for you. And that's a huge gap, right? Going from life-saving therapy everyone needs, you got to talk me out of why I'm not going to prescribe you this, to, oh, I'm sure that this isn't for you. And so I just wanted to, through this talk, to sort of review how evidence-based is this dogma actually, because I think in a lot of ways it's something that we sort of just all assume is true, but I wanted to do a bit of a dive into how evidence-based that is, and kind of ask the question through this, which is intended to sort of, we don't want to prescribe beta blockers if they're going to cause harm. Are we actually instead perpetuating unequal access to care that patients who have substance use disorders so often face? I just want to, this is a very medical topic, and I'm aware that some people may have less familiarity with managing various cardiac conditions. So just a bit of background knowledge, terminology, just sort of make sure that everyone is along. So one thing you're going to see in this talk is CMO, or cardiomyopathy. It's just a generic term for diseases of the heart muscle. Another thing you'll see is CHF, or congestive heart failure. Congestive heart failure is a condition in which the heart is unable to meet the metabolic needs of the body because either the heart's unable to squeeze properly or it's unable to relax properly, or a bit of both. You'll also see HFrEF, or heart failure with reduced ejection fraction, and that's a subtype of congestive heart failure, specifically where it's that pumping function, the squeezing function of the heart that's reduced, and in particular, we define this as an ejection fraction of less than 40%. Another bit of just sort of background information, just to sort of set the stage, is just to point out that in this literature that we're going to be going through, for the most part, papers tend to focus on a specific stimulant. They look at, for example, does cocaine increase your risk of having a heart attack? Or patients who have methamphetamine-associated heart failure, is it safe for them to be on a beta blocker? I think in a lot of ways it makes sense for us to separate the literature out in that way. After all, these drugs have very different pharmacokinetics and pharmacology. Their mechanism of action is different, and additionally, the half-life, for example, of cocaine is about an hour, give or take. For methamphetamine, it's 10 or 11 hours. So it makes sense that these substances may have different cardiac effects and different safety profiles. On the other hand, I think it does lead to quite a bit more fragmentation of the literature. Often we think of these substances as somewhat interchangeable when we talk about a substance use, or pardon me, a stimulant use disorder. And then often patients may use multiple types of stimulants. So I just wanted to bring this up as just sort of something to keep in mind when we're interpreting the literature. And also to point out, you're going to see that a lot of the literature is on cocaine induced coronary disease and cardiomyopathy. And there's been a big extrapolation to methamphetamine, which is becoming an increasingly used substance. Also, just a disclaimer, I'm going to focus for the most part on cocaine and methamphetamine because that's where most of the research is. We won't be talking so much about MDMA, synthetic cathinones, or prescribed psychostimulants. So regarding our first objective, just setting a bit of a background about the epidemiology of stimulant use disorder. Using stimulants is a very, very common thing in Canada. As per the Canadian Tobacco, Alcohol and Drug Survey conducted in 2017, 10.4% of Canadians reported having used cocaine or crack cocaine at some point in their lifetime. So that's over 1 in 10 Canadians. The number for methamphetamines was nearly 4%. And in terms of more frequent use, within the past year, 2.5% of Canadians reported using cocaine or crack cocaine. So stimulants are widely used substances, and if they have cardiac effects, it's important for us to know about them. Just a little bit more about that epidemiology. This is data specific to Vancouver. The authors here looked at 2 data sets, specifically looking at people who use injection drugs in Vancouver. and the reported rates of crystal methamphetamine use within the last 6 months. And the reason I want to bring this up is twofold. One, just to show how high these rates are. So looking at 2016 to 2017, 40% of people who report injecting drugs in Vancouver also reported using crystal methamphetamine in the last 6 months, so very high. And also there's been this trend from 2006 to 2016, 17 of an increase in crystal methamphetamine use. And it's not graphed here, but if the amounts of cocaine use were also graphed, that correspondingly has had a decrease. There's been a bit of a shift away from cocaine to methamphetamine, at least here in Vancouver, which again is important given that a lot of the literature is on cocaine. We're really extrapolating it to methamphetamine. Not only are these substances commonly used, they're also associated with significant hospitalizations. This is data from the United States, where they have a database that captures hospitalizations covering about 97% of the US population. And they looked at hospitalizations where ICD-9 codes associated with amphetamine use were listed as one of the reasons for hospitalization. And amphetamine-related hospitalizations have absolutely skyrocketed over the period of 2003 to 2015, to the point where in 2015, there were just over 200,000 amphetamine-related hospitalizations in the United States, compared to just over 50,000 in 2003. So that's almost a quadrupling over 12 years. Additionally, they note in this study that patients who had an amphetamine-related hospitalization had higher rates of mortality, longer length of stays, and significant costs associated with hospitalization. There was $2.17 billion estimated to be the annual hospital-rated nationwide healthcare expenditures in 2015. So stimulants, including amphetamines, are widely used and have significant associated healthcare burden. With respect to their connection to cardiac disease, I'll start just by setting the stage with a little bit of pathophysiology as to how it is that methamphetamine and cocaine may contribute to cardiac disease. And I think when I started this talk, I sort of had the idea that the main thing going on here would be that catecholamine excess, or the high blood pressure, high heart rate kind of toxidrome that would just sort of put strain on the heart. And that is indeed one of the mechanisms through which substances, for example, here, they're looking at methamphetamine, causes cardiac toxicity, is that catecholamine toxicity in the brain. There are also actually direct effects through which methamphetamine and cocaine bind to important cellular signaling pathways in the heart and in the vasculature, and further contribute to cardiac disease. This is sort of like the token pathophysiology slide that all of these talks need to have, with like a lot of arrows and small text. Please don't get caught up in the details here, but I just again wanted to give a bit of an idea of like what are some of the ways that methamphetamine and cocaine may be related to cardiac disease. So on the top left here, we have some mechanisms related to pulmonary hypertension. And you can see that methamphetamine has been associated with decreases in certain signaling pathways called the ROS pathway and the endothelin-1 pathway that decrease nitric oxide sensitivity and cause pulmonary hypertension or vasoconstriction. In the bottom left, with respect to the link to arrhythmias, methamphetamine has been associated with QT prolongation, but then also with structural remodeling in the heart, more inflammation in the heart, fibrosis or scar tissue in the heart, and then also electrical changes in the potassium and calcium channels that regulate electrical activity in the heart. And so when those things happen together, you can see how there's going to be an increased burden of arrhythmias potentially. In the bottom right, there's sort of explained pathophysiology related to cardiomyopathy. A number of mechanisms have been identified around inflammation, fibrosis, mitochondrial dysfunction. And in the top right, connections for coronary artery disease. So methamphetamine has been associated with increased activation of the endothelial cells and increased inflammation, which can lead to more plaque formation. So there's been a bunch of work that's demonstrated, this slide's about methamphetamine, but cocaine similarly has been evaluated in this way, that at a cellular level, there are all sorts of ways in which these substances may contribute to cardiac disease. I wanted to try and, for this next part, get a little bit of a sense of, well, one, proving to you that in the real world, outside of the lab, in the real world, that do we actually see increased risk of cardiac disease with these substances? And then two, get like a little bit of an idea of like, how big is the risk? If you're talking to a patient and they're using, for example, methamphetamines every day, what is their risk of developing a certain cardiac disease? And unfortunately, just based on the study of the literature, it's a little bit hard to come up with a number like that. But I do think you can get a bit of a sense of, these conditions are indeed associated with stimulant use. This is a paper about cocaine use and the likelihood of myocardial infarction. It was a survey of 10,085 US adults aged 18 to 45, so that's relatively young to be having a heart attack, on common health conditions. 46 participants self-reported a history of a heart attack, so a relatively low number out of 10,000 people. And then of those 46 people, patients with reported cocaine use had a much higher likelihood of having been one of those people who reported having a heart attack, with an odds ratio of 7. They calculate something called the population attributable fraction, which is some sort of fancy stats work to demonstrate that of all the heart attacks in that age group, approximately 25% of them can be accounted for by heart attacks that were associated with cocaine use. So giving us a bit of an idea, it seems like cocaine use is associated with non-fatal heart attack in young people. What about arrhythmias? So this is a study published in a bit of a smaller journal, you can see in the top left there, where they looked at a cross-sectional study of patients with cardiac complications, 230 patients presenting to the ED with a complaint related to amphetamines. And then they looked at various cardiac complications, including arrhythmia. And they observed that 3.5% of patients had arrhythmia, although they sort of lumped together some arrhythmias which are quite concerning, like ventricular tachycardia, and then some other arrhythmias which are not so concerning, like PACs. They also showed that 35%, very high percentage of people, had a prolonged QT. With respect to pulmonary hypertension, so flipping back to cocaine here, this is a study in which the authors looked to see whether cocaine use was associated with pulmonary hypertension. And they did a retrospective chart review of 88 patients with known cocaine use and compared them to 58 patients without cocaine use and without any other risk factors for pulmonary hypertension. And then they looked at echoes that had been done at this particular center in California. This study was published in the American Journal of Cardiology. And they demonstrated, with an echo, you're not able to diagnose pulmonary hypertension, which is a condition which presents with shortness of breath. It can make people quite unwell, but you can create sort of a likelihood of how likely they will be to actually have pulmonary hypertension if they went on to get the confirmatory test. They found that in the cocaine group, a quarter of patients, 25% of patients, had intermediate or high probability of having pulmonary hypertension, whereas that number was about 10% in the control group of patients who did not use cocaine. So again, suggesting pulmonary hypertension is associated with cocaine use. Similar data exists for methamphetamine. This is another study where they looked at patients who had died in Australia from 2009 to 2015 and had an autopsy performed, had a sort of a coroner's investigation. And they were able to identify 894 persons who had methamphetamine-related deaths as judged by the coroner, and then looked at autopsy reports to see what the burden of cardiac disease was. About 50% of people who had died, the cause of death was judged to be methamphetamine-related poisoning, and sort of 20% had died, that was the second most common cause of death, from cardiovascular disease. The mean age was relatively young for cardiac disease, 36.9, and they found, one, that 19% of patients had coronary artery stenosis, about 75%. So you shouldn't have coronary artery disease, especially significant coronary disease when you're 37 years old. 5.5% had a cardiomyopathy. They don't say exactly how they defined cardiomyopathy, but the coroner had said there was a cardiomyopathy. And then a very high percent, 26.3%, reported cardiomegaly, which means that the heart is enlarged. It's greater than the 95% upper limit of normal for weight. So these are patients who had died, so perhaps a little bit enriched in terms of cardiac disease compared to other patients who use stimulants, but suggesting relatively high burden compared to the population. So what about patients who develop a cardiomyopathy? What is sort of their natural history? In particular, what is the likelihood that they'll have recovery of their cardiac function? This was a study that looked at patients with methamphetamine-associated cardiomyopathy or heart failure. And they specifically looked at people who had an ejection fraction less than 40%, which would mean they would be in that HEF-REF category I talked about before. And they followed them, 357 patients, over a median follow-up of 45 months. And these were patients that were being seen at a particular hospital in California. And they demonstrated that a significant percentage of these patients actually do have recovery of their cardiac function, where their pumping function of the heart goes back to normal. That occurred in 30% of participants. So not all patients, unfortunately, that do develop recovery, but a significant proportion that do. And interestingly, they looked at factors to try and predict, well, what types of patients are likely to have this recovery? And well, one, they found that cessation from methamphetamine use was highly associated with recovery of cardiac function. And then another one, and they use sort of unfortunate term compliance from with heart failure therapy, but basically participation in standard therapies for heart failure with reduced ejection fraction. For the most part, they're actually focused just on attending clinic appointments, was associated with improved function. So certainly not causal, but there's an association there that there's some things that maybe we can do to help people get their cardiac function back. This is really important because that same study also looked at survival, and they found that patients who had recovery of their cardiac function had much, much higher chances of living compared to patients who do not have recovery of their cardiac function. So this is a graph here. On the x-axis, we have follow-up, and on the y-axis, we have survival. And the blue curve is patients who did not have recovery, and the green curve is patients who did have recovery. You can see there's a significant difference where very quickly there's more and more patients that are dying in the group without recovery. The numbers are high. So over the 45-month follow-up, 28% of patients that did not have recovery passed away, whereas that number was just 6.5% in the group with recovery. So this is a condition that has significant mortality. And if there are things that we can do to promote recovery of cardiac function in methamphetamine-associated cardiomyopathy, it seems to have quite a marked impact on survival rates. So that's where beta blockers come in. Beta blockers are a class of medications that block the effects of epinephrine and norepinephrine. You may also know these hormones as adrenaline and noradrenaline. They're widely used in cardiology. These are like the foundational building blocks of what cardiologists do, and are first-line therapies for numerous conditions, including coronary artery disease, heart failure, tachyarrhythmias, and hypertension. These medications are very important. So to give you an idea of just how much of an impact beta blockers have, I've gone back to one of the sort of foundational initial studies that demonstrated the benefit of beta blockers in heart failure. This is the Copernicus study, which showed benefit for carvedilol in heart failure with reduced ejection fraction. They're not specifically looking at stimulant-associated heart failure here. This is all comers, people with heart failure with reduced ejection fraction. And they specifically looked at quite a sick population with EFs of less than 25% and quite significant symptoms. And they find that there is a marked difference in terms of the annual rate of death, of all-cause mortality, just from the addition of this one medication, carvedilol, which is a type of beta blocker. In particular, they find a 35% relative risk reduction. The annual death rates in the group that were not treated with carvedilol were 19.7%, and they're just 12.8% in patients that are treated with carvedilol. In fact, the study is stopped early because the ethics panel said that it would be unethical to withhold beta blocker treatment for these patients, knowing what they know. I'll just repeat that. They thought it would be unethical to withhold beta blocker treatment based on the results of this study. So in contrast to that, we have the concern in the context of people who use stimulants. Again, this is this AHA consensus statement from 2008, in which they said specifically for the management of cocaine-associated chest pain and myocardial infarction, we think that beta blockers are unsafe. The kind of core reason that people are concerned about the safety of beta blockers in the setting of stimulant use is a phenomenon called unopposed alpha receptor stimulation. So to understand why beta blockers might not be safe, you need to understand this phenomenon. And To understand this phenomenon, you have to know a little bit about how the sympathetic nervous system works. So the sympathetic nervous system exists to sort of mediate our fight or flight response. So you can think of in all of the organs in your body what you would want to happen if you were to run away from a bear or something like this. And there are receptors throughout the body on all sorts of different organs that mediate this response. We'll focus on the receptors that sort of are existing on the heart and vasculature, because we're talking about sort of cardiac disease. So in a patient who uses stimulants, that's going to result in the release of certain hormones called norepinephrine and epinephrine. And these hormones work to bind receptors called the beta-1, beta-2, and alpha-1 receptors throughout the body. The beta-1 receptors exist mainly on the heart, and they have the effect of increasing cardiac output. They make the heart beat faster and beat more strongly. There are beta-2 receptors. These receptors exist on smooth muscle and cause relaxation. And one of their main functions is they live on the vasculature in large skeletal muscles. So for example, the muscles in your legs, so that the arteries will dilate to provide more blood flow to the muscles in the legs so that you can run away from a bear or do whatever you need to do. There are alpha-1 receptors. These receptors exist on other arteries throughout the body and cause vasoconstriction. They cause the arteries to sort of clamp down, which has a similar effect to if you imagine sort of putting your thumb on the end of a hose. By making the diameter of the hose smaller, the pressure increases and the water sort of shoots out of the hose. So those alpha-1 receptors have the effect of increasing your blood pressure. So that's what happens in somebody with sort of normal physiology using stimulants. But what happens if you put beta blockers in the mix? Now all of a sudden you've blocked the beta-1 and the beta-2 receptors. And so theoretically, now these alpha-1 receptors are operating all on their own, and we just have that vasoconstriction limb. And so the concern, the theoretical concern, is that this will lead to more hypertension and also potentially ischemia of the heart, cardiac ischemia, because the arteries that supply the heart with blood may clamp down a little bit because of that alpha-1 receptor effect without the normal compensatory beta-2 effects. So that's the theory of why this might be a problem, but does it actually happen in the real world? The kind of origin of the dogma that made people concerned that this may actually be a real phenomenon is a study performed in 1990, so it's 31 years ago, in which they took 15 clinically stable volunteers and they did a procedure called cardiac cath on them, or catheterization. That's a procedure where they put a catheter up through the femoral artery, thread it up to the heart, and then actually into the arteries that supply the heart with blood and inject dye. This would be the same procedure that they do to like insert a stent, things like that. And they gave these patients, after performing the cath, they gave these patients intranasal cocaine, and then half of the patients got saline, which would be placebo, and the other half got intracoronary propranolol. They actually inject propranolol, which is a beta blocker, directly into these people's coronary arteries, which is not a thing we normally do. And they were able to demonstrate that there was increased vasoconstriction of the coronary arteries after propranolol was given. They showed, however, there was no increase in systemic blood pressure, which we would expect with this unopposed alpha. And then they did show that one patient had a STEMI, which is a type of heart attack, after propranolol was given. And you can see here the images, this artery, I don't know if you can see my mouse here, but there's an artery here that had contrast going through it. And then after propranolol, it's blocked off. And so that was reversed with nitroglycerin and the patient did fine. This, though, is what led to concern. Maybe this unopposed alpha thing is real. Maybe beta blockers aren't safe. As a follow-up, somebody did a study with labetalol. Labetalol is a beta blocker that also blocks alpha-1. And so theoretically would have less of this risk of the alpha-1 receptors sort of operating in isolation. Again, they gave intranasal cocaine during a cardiac cath, and then they gave intravenous labetalol. And this time around, they saw no vasoconstriction, nothing bad happened, nobody had a heart attack, and the systemic blood pressure went down instead of up. So seems actually like for labetalol, not a concern. What about outside of the cath lab though? What about in terms of the real world? A patient comes into you and sees you in your office. Is it safe to give them a beta blocker? This is a systematic review published in 2016 of 50 studies covering 1,744 patients regarding the treatment of acute hyperadrenergic symptoms from cocaine toxicity. So this would be like people in the emergency department, for example, coming in with cocaine chest pain, associated chest pain, or with just a high heart rate and high blood pressure in the context of cocaine use. And they find that across all of these patients, there's just 7 instances, 7 case reports in the entire cardiology literature of possible episodes of unopposed alpha type phenomenon happening. Not confirmed, not something bad happened to the patient, but just maybe the blood pressure went up a little bit. Maybe there's a patient where some chest pain recurred, something like that. And the authors of these case reports proposed that maybe there had been an adverse effect from the beta blockers. They don't identify a single case report of adverse effects from a beta blocker that has alpha blocking activity. And they find actually that for the most part, beta blockers are effective treatments for hyperadrenergic symptoms. They cause the blood pressure to go down, the heart rate to go down, just like we would expect. This is another systematic review of by the same authors for methamphetamines, published in 2015. There's not quite as much literature on this, so there's 9 clinical studies and 10 case series / reports comprising 227 patients. And again, we find just 3 cases in the entire cardiology literature as of 2015 where there was a possible association between beta blockers and unopposed alpha. Again, they identified numerous case series or case reports where the opposite happened. Beta blockers were given and they did what they're supposed to do and the patient got better. So there's sort of these 10 adverse events. I wanted to dive into one of them to give you a bit of an idea of what these adverse events are, because this is sort of the other part of the literature that would support maybe there is something to this whole unopposed alpha thing. This is with methamphetamine, and it's a case of a 37-year-old female who had a history of IV amphetamine use and presented with a heart attack with STEMI. It was in 1993, this case, and so she was given thrombolytics, and which is like a clot buster drug. She actually had a failed reperfusion, which means the thrombolytics didn't do anything, they didn't work. Interestingly, she did not actually endorse any recent amphetamine use. Her urine drug screen was positive, and she reported being on an over-the-counter cold medication recently. She ended up staying in hospital, and on day 6 of hospitalization, she was started on that same beta blocker that was implicated in that other problematic study, propranolol, an oral dose of that. She had 1 dose, nothing happened, and then a 2nd dose, and after the 2nd dose, her chest pain came back. She'd been sort of fine in the hospital for 6 days. Her chest pain came back, and she had another heart attack. Specifically, we did an ECG, and it showed recurrent ST elevation MI. That resolved with nitroglycerin, and she went on to have an angiogram that showed no atherosclerosis. They said this is probably vasospasm. She was discharged home. 4 weeks later, she came back to hospital with recurrent chest pain and actually died. And at that time, her urine drug screen was negative for amphetamines. And so the authors of this case report proposed that the propranolol had caused unopposed alpha receptor stimulation and caused her to have a 2nd heart attack. And I think if you look at this case, like, that's a little bit of a dubious conclusion. Like, first of all, she did not actually report any active amphetamine use. She said that she was on an over-the-counter cold medication, which could indeed cause her UDS to be falsely positive. Secondly, it was day 6 of her hospitalization that she was given propranolol and developed chest pain. And methamphetamines have a half-life of approximately 10 to 12 hours. And so that would be over 12 half-lives for the drug to be metabolized, which would mean there's no methamphetamine in her system at that point, for which propranolol could then exert like an unopposed alpha type event. So that doesn't really make sense. It's also funny that the 1st dose of propranolol didn't cause any problems. It was only the 2nd dose. And then 4 weeks later, she came back to hospital and had the same thing happen to her, and there was no amphetamines in her urine and no beta blockers were given. So I don't know exactly what happened to this woman. But my point is, oftentimes these adverse events it's a little bit dubious as to whether or not beta blockers are actually to blame here. And there are other cases that are more convincing than this one, where at least the temporal association makes more sense. But ultimately, they're all just cases where someone showed up to the emerge, they got some nitro, their chest pain went away, then they got a beta blocker, their chest pain came back. Maybe those are connected, maybe they're not. It's relatively low quality evidence. And so what happens if we look at some of the higher quality evidence at larger cohorts looking at many patients? This is a meta-analysis done in 2018 of 5 different retrospective cohorts comparing the outcomes of patients presenting with cocaine-associated chest pain that were either treated with or without a beta blocker. They found that there was no difference in the rate of non-fatal MI or in-hospital all-cause mortality. And in fact, there was a trend, a non-significant trend towards lower mortality in the beta blocker group. So in the real world, when you look at a whole bunch of patients coming to the eMERGE with cocaine-associated chest pain, and a bunch of them get beta blockers and some of them don't, and then you look back at the data and say, who did better? It doesn't seem like all the people who got beta blockers had a bunch of unopposed alpha type events or died more often or anything like that. What about for heart failure? So this is a 2020 systematic review of 3 different retrospective cohort studies comparing outcomes of patients with cocaine-associated cardiomyopathy treated again with or without beta blockers. The authors conclude that there's insufficient evidence to suggest any harm. They note that there's relatively low quality evidence, and so it's somewhat limited in terms of an ability to demonstrate benefit. But they do show, one of the studies that was included showed significantly reduced 30-day hospital readmission rates in the patients who were treated with a beta blocker. And another study showed that patients who were treated with a beta blocker had reduced NYHA class and improved EF with a beta blocker, improved ejection fraction with a beta blocker. So again, this is retrospective cohort data. It's not a randomized controlled trial. There's potential for confounding, but it doesn't suggest that the patients treated with beta blockers did worse. In fact, there's maybe some suggestion that they may have had better outcomes. This is another study of regarding cocaine-associated cardiomyopathy. It was published after that systematic review I just showed you, so that's why it's not included in it. They looked at 503 patients with cocaine-associated cardiomyopathy again, and in this case, they were specifically treated with carvedilol, which is another beta blocker that has alpha blocking activity, and so again, theoretically, maybe safer. And in the subgroup of patients with heart failure with reduced ejection fraction, which is the type of heart failure for which beta blockers are useful, they found that, again, there was this trend towards benefit, not harm. Patients had reduced CVD death, or reduced cardiovascular death, and reduced heart failure readmission rates if they were on a beta blocker. And those are the percentage rates that were observed of the sort of composite outcome of cardiovascular events. In patients with heart failure with preserved ejection fraction, there was no difference in terms of their outcomes, which makes sense because beta blockers aren't actually indicated in that population. So you can see here the curves in terms of survival, where the patients without beta blockers are doing worse. So that's the evidence. I wanted to sort of go through some of the guidelines, though, because I think that given that this is an area maybe with a bit of controversy, maybe a year from now you don't remember all of this evidence, and you might be feeling nervous about going against the standard of care. You might be feeling like, well, maybe this whole beta blocker thing isn't all it's chalked up to be, but all my other colleagues are not prescribing beta blockers, so I'm nervous about going against a standard of care. And I think guidelines very often end up representing for us a standard of care. I want you to look and see what do the guidelines actually say. The only guidelines that really make a specific statement about not using beta blockers are ones pertaining to acute coronary syndromes or heart attacks. This is a guideline regarding non-ST elevation MI, the 2014 AHA guidelines. And it's very specific. They say patients who have cocaine or methamphetamine related non-ST elevation MIs, a type of heart attack, should be treated the same as other patients, is what they say, unless they have acute intoxication with cocaine or methamphetamine. And then they make a bit of a caveat that maybe it would be okay even then to use a beta blocker if the patients are receiving coronary vasodilator therapy first, like nitroglycerin, something like that. So it's very specific, right? They're not saying all patients, they're saying you're having an non-ST elevation MI and you're acutely intoxicated with cocaine, don't give this person a beta blocker. With respect to heart failure, there are no guidelines that tell us this is not a safe thing to do. The only mention that I was able to find of this is a very old guideline from 2013, the American Heart Association guidelines for heart failure, and they just make a comment, the safety and efficacy of beta blockers for chronic heart failure due to cocaine use are unknown. Not that it's safe, not that it's unsafe, just that it's unknown. And their reference here is just that 2008 consensus statement about cocaine-associated MI. in beta blockers that I showed you earlier. So they're just saying, well, maybe it's not safe in cocaine-associated MI, so we don't know about heart failure. But there's no guideline that says you should not do this, and there's no mention at all in the Canadian guidelines of it. This is a review paper that was published in a large journal, the Journal of the American Heart Association. It was a review about the management of methamphetamine-associated cardiomyopathy, and while it's not a guideline, it is a review paper in a very reputable journal that was published much more recently than those other two guidelines I showed you. And they say that patients with methamphetamine-associated cardiomyopathy should be treated with guideline-directed medical therapy for heart failure with reduced ejection fraction, which means beta blockers, among other therapies. I think another point that might be important to make is just distinguishing a little bit different types of beta blockers. Because again, I have given you this sort of explanation of a beta blocker blocking the beta 1 and the beta 2 limbs, and alpha 1 receptors from being left all on their own and not causing unopposed alpha. But what about if we use a beta blocker that specifically just targets the beta 1 receptors? And in fact, that's actually how most of the beta blockers that are now used in cardiology and that would be used for something like heart failure work. We don't really use propranolol very often anymore, and you'll note that a lot of those studies were very, very old, back in the early 90s. And so if you use a beta blocker like propranolol, or like metoprolol, it's only blocking beta 1, now all of a sudden that beta 2 limb is fine, is not affected, and we have that smooth muscle relaxation that can help to balance out some of the vasoconstriction from alpha 1 receptors. And so instead of hypertension and ischemia, there's a bit more balance. What about if we use a beta blocker that has alpha blocking activity, like carvedilol? And so instead of just blocking beta 1 and beta 2, it also blocks the alpha receptors. And again, instead of hypertension and ischemia, there's balance between all these different limbs. You might argue, well, that's just theoretical. How do you know that's true? Which I would sort of argue back, well, so is all of this. And then when you go back and look at the evidence, it does seem like potentially it may be supported that some of the other beta blockers that are either target just beta 1 or also block alpha may be safer. Remember, there was that cardiac catheterization study where they repeated it with labetalol and nothing bad happened. There was no vasoconstriction. Remember that those systematic reviews that looked through the literature for management of acute cocaine and methamphetamine toxicity were unable to identify a single case in the entire cardiology literature of unopposed alpha receptor stimulation happening after a beta blocker with alpha blocking activity was used. And also, I'll just point out there was that cohort study regarding cocaine cardiomyopathy and carvedilol, which is a beta blocker with alpha blocking activity, that suggested there was some benefit. So maybe the evidence supports to that distinguishing kind of the mechanisms may be important. So to summarize the evidence, there basically are a handful of case reports and a single cardiac catheterization study, and also some animal studies that suggest possible episodes of unopposed alpha receptor stimulation occurring. But another cardiac cath study and lots of other case reports have not shown any harm. When we look at larger cohort studies and systematic reviews of patients with either cocaine-associated cardiomyopathy or cocaine-associated chest pain, those also have not demonstrated harm, and in most cases have demonstrated benefit. And in addition to this, when we look at the cardiology literature in general, beta blockers are well-established life-saving therapies in heart failure with reduced ejection fraction and other conditions, and they have a large magnitude of benefit. When we go back and think about that Copernicus study I showed at the beginning, this isn't a small thing to withhold these medications. They work very, very well. So at this point, you might be feeling a bit perplexed as to what you actually do as a prescriber, or maybe you're a patient and you're wondering, what should I ask for? How do I kind of navigate this in terms of a practical sense? And so I kind of just wanted to propose my own opinion about how we navigate this. I think it's important to frame this within the recognition that people who use substances often face unequal access to healthcare. And when we restrict access to beta blockers, we may be unintentionally restricting access to a life-saving therapy and further perpetuating that unequal access. In light of that kind of ethical principle, I'd remind you that the current evidence does not clearly demonstrate harm for beta blockers in the setting of stimulant use, especially when we look at long-term use, things like cardiomyopathy. And so while there is no randomized controlled trial that clearly demonstrates that in patients with methamphetamine-associated cardiomyopathy, people randomized to a beta blocker did better, I would say that until harm is demonstrated, most prescribers should be taking the approach that patients should be delivered the standard of care, just like all other patients with heart failure with reduced ejection fraction. And if you are feeling like there's some uncertainty in this area, I think an approach, rather than taking a stance of not offering the therapy and viewing stimulant use as a hardline contraindication, to instead consider talking about it with your patient and having a bit more of a shared care approach where you discuss the risks and the benefits and people can decide for themselves whether this is a therapy that they'd like to try. Another opinion piece, I do think that this distinction between the mechanisms of beta blockers is important. And if you're worried about unopposed alpha, you can think about using a beta blocker like carvedilol or labetalol. Again, they're theoretically going to be safer, and there is some evidence that seems to suggest that that's true. I also think that it might be important as prescribers and as patients to think a little bit about a distinction between what the beta blockers are being used for, and in particular, whether it's an acute indication for a beta blocker or a chronic indication. Think about somebody with an acute indication for beta blocker, maybe they're presenting with an MI. In that situation, there are clear guidelines that suggest that beta blockers are not safe for people presenting with acute MI and acute intoxication. There are alternative treatments that you can use instead. You can manage their hyperhidronergic symptoms, for example, with benzos. You could give nitroglycerin to relieve ischemia. So you're not quite so reliant on beta blockers. Additionally, the degree of benefit and the urgency in this situation is maybe less. Beta blockers in the setting of MI should be given within the first 24 hours is what the evidence is for, as opposed to being you need to give them right there as soon as the patient walks through the door when they're having acute toxicity. And also, I think it theoretically makes sense if someone's having an MI, they're having acute ischemia, and so maybe even minor changes that could increase ischemia may be more significant for them. Now compare that to somebody presenting with heart failure with reduced ejection fraction. You're not going against any guidelines by prescribing a beta blocker. There are really no alternative medications that would replace a beta blocker in this situation, so you're denying your patient this significant life-saving therapy. Oftentimes, the benefit size is very large, and theoretically, they're not having acute ischemia in that minute, so maybe they're a bit less sensitive. I've also heard the argument before, well, none of this matters because patients aren't going to take the medications anyway, which I think is already just an extremely problematic statement in terms of the stigma that comes along with that type of statement. But I think it's also one that just is untrue. And while I don't have data specifically about rates of people taking beta blockers who have a stimulant use disorder, I wanted to borrow some literature from another field, which is the hepatitis C literature. And for a long time, people thought that if people have hep C and they're actively using drugs, we shouldn't treat their hepatitis C. And there were even guidelines that suggested this was the case because maybe they're not likely to take the medication, or they could be reinfected, or they might develop resistance. And recently there was a trial that sort of challenged this. It's called the Simplify trial. It was published in The Lancet, a very prominent medical journal. And they took 103 people who had hep C and had used injection drugs within the last 6 months, and they gave them treatment for their hep C and then followed them and saw how successful are these treatments. It was a patient population that had quite significant injection drug use, so over a quarter reported over daily injection drug use over the last month. And they demonstrated that outcomes were very, very good. 97% of patients completed treatment. 94% of patients achieved cure of their hepatitis C, which is comparable to the cure rates in other populations. And the degree of substance use before and during treatment had no impact on how likely people were to have cure. And on the right, this is a schematic where they charted whether patients were taking their medications on each day, and they used these electronic blister packs so they could measure on each day whether a patient took their medication. And each row represents one patient, and a green dot means that the medication was taken, and a yellow dot means that it was missed for a day. And you can see that, like, overwhelmingly, it's mainly green dots. There's occasional periods where patients were not taking their medications, but for the most part, people did, and resultantly, it was a very effective therapy, and disproved the previous stigmatizing belief that these patients shouldn't be offered treatment for their hepatitis C. So in summary, cocaine and methamphetamine use is associated with increased risk of a number of cardiac diseases. Those include cardiomyopathy, coronary artery disease, pulmonary hypertension, and also arrhythmia. Stimulant-induced cardiomyopathy is a particularly important condition and one that has a very high mortality rate, although abstinence from stimulants was highly associated with recovery of cardiac function and also reduced mortality. Other kind of key points I think to take home is that it's my belief that clinicians should reconsider a hard-line contraindication to long-term beta blocker use in the setting of active stimulant use. Instead, I would advocate for considering a sort of shared care decision-making structure with your patient. I would advocate for considering a distinction between beta blockers in the setting of acute stimulant intoxication and MI versus more long-term indications. And then I would advocate for considering using a beta blocker with alpha blocking activity, such as labetalol and carvedilol. So that's the end. I just have a few pages of references here. And then just some acknowledgements. Just wanted to thank Dr. Paxton Bach, who's been a research mentor for me on a narrative literature review that we're doing on this topic and hope to publish. And then also a friend and colleague of mine, Dr. Ian Fisher, who's provided some valuable cardiology insights. So with that, I'll go back to this picture of our infused goat and yeah, just open the floor up for any questions.
Maybe saying he's the goat. Yeah.
Thank you, Tyler, for an excellent talk. I think that's really thought-provoking. It's super important in this hospital because we see this question come up so often. So a great overview of the data. I will open the floor to questions. I'm just going to read these out. So please feel free to write these into the text box as needed. So the first question here is, in practice, sometimes beta blockers are prescribed for clozapine-induced tachycardia in patients who also have methamphetamine use disorder. Since there isn't clear mortality benefit to treat clozapine-induced tachycardia, should this practice be discouraged?
Yeah, I mean, I guess in general, I think I'd start by just wondering who would be treating clozapine-induced tachycardia. I can't say I know a ton about sort of the outcomes of clozapine-induced tachycardia, but I would agree that there's not great evidence that you're going to be causing any significant improvement for the patient. I think maybe the one caveat would be if somebody had symptoms related to their clozapine-induced tachycardia, like they were having palpitations, for example, that might be a reasonable reason to prescribe a beta blocker. And so then I think you just have to, like anything, consider the risks and benefits. And if a patient is, let's say, having significant symptoms, or maybe their heart rate is very high, like it's like, I don't know, 140 or something, and you're worried about them developing a cardiomyopathy from the prolonged tachycardia, then you talk to the patient about it and say, there's maybe some risk associated with beta blockers. People have, there's been some concern that this could increase risk of heart attack, but for the most part, newer evidence has shown that it's safe, and I think for you that it's likely to be a safe treatment and might be helpful for your palpitations. And then I think the patient can make an informed decision. But I would share your concern about contextualizing the prescribing within sort of what type of benefit you think that you're going to get out of just like any therapy.
Excellent. We have a couple comments here. This is the best deep dive on the subject that I've found. Thank you so much for reviewing this important issue. And I tend to agree. I think that was just an excellent summary of the literature in this area, Tyler. And another question here. Other than a randomized control trial, which may be hard to fund, and as an aside, I would argue based on the data that you just showed me that
Yeah.
it may not even be ethical. What is the next step to study this in a way that will generate new clinically useful evidence?
Yeah, that's a great question. I mean, personally, I feel pretty convinced in the context of cardiomyopathy that these therapies should be prescribed. I suppose it would be helpful to have larger cohorts with more patients at more centers, you know, retrospectively looking and or ideally prospectively at outcomes for cardiomyopathy. I think other useful data would be around other beta blockers, not just carvedilol, but in particular bisoprolol. To me, I could see that being a question because bisoprolol is a beta-1 selective beta blocker, and I had mentioned earlier there's maybe the best or safety around beta blockers that have alpha blocking activity, but there is the disadvantage that carvedilol is dosed twice daily, and so I could see for some patients they might say, well, I'd rather take a once daily medication. I would feel more comfortable if somebody could provide good sort of cohort data about beta-1 selective beta blockers in cardiomyopathy. And then definitely the cocaine-associated MI data, like, yeah, I share your concern about randomizing people. I don't know if that's ethical to do, but well, maybe in cocaine-associated MI, there's enough clinical equipoise to justify an RCT. I'm not totally sure, to be honest, but I don't know if I can add more to that. But with respect to the cardiomyopathy questions, I'd say those are the areas I'd like to see researched, and I agree that an RCT there is probably not ethical.
Okay, so we're getting close to 1 o'clock. I don't see any further questions. So I just want to thank you, Tyler, again for an excellent presentation today, and thank the audience for tuning in. And that will be a wrap for our What's New Addiction Medicine presentations for this cohort year. So thank you, everyone, for sticking with us through the year, and we will be in touch soon with our next cohort.
Thanks very much, everyone, and thanks, Paxton.